on buccal mucosa. I think this is a very practical tip because this we have to encounter on and off in our life, and it's basically a bridge to patient ending up into hospital. So my job is to talk about lipodystrophy. I'm thankful a lot of learned people standing in here. Dr. A.K. Singh, thank you sir for coming, and Dr. Shukla and all of them. So we have been using insulin day in and day out, and I think we must spend some time with the patient talking about insulin injection techniques and proper storage, rotation of the sites, and how to prevent these local skin complications. There can be so many skin issues with patients on insulin, but I think lipodystrophy is one of the important ones. And because of busy practices, sometimes we feel that these children, particularly type 1 diabetes or type 2 diabetes, basal and bolus, they are not responding to insulin and the HbA1c is high. And when you look at the sites, there is either an abnormal thickening, so suggesting that there is some sort of lipohypertrophy which is present. So we must spend time, I think, talking about insulin injection techniques. I think we can have a full couple of hours discussion talking about this. So these are the two common, I think, lipohypertrophy and lipoatrophy. But lipoatrophy we rarely see these days because of availability of human insulins. I think it was more common with bovine and porcine insulins. But lipohypertrophy is the commonest lipodystrophy we see. Any other lipodystrophy? Is anything left, or these are the two lipodystrophies? I was going through the literature and Mayo Clinic proceedings. They also suggest that rarely you can encounter another form of lipodystrophy. Lipohypertrophy is definitely the commonest one, but the another rare is amyloidosis. This is sometimes called as insulin balls also. Short of histopath diagnosis, you cannot make the diagnosis, but you see in histopath are sometimes bifringent crystals. And surgical removal is the only therapy if there is a localized thickening. It just mimics as lipohypertrophy, but it's not a lipohypertrophy. In fact, it's a local amyloidosis. So these are the three mentioned in the literature: lipodystrophies, hypertrophy, atrophy, and amyloidosis. So if you look at the histological features, the underlying mechanisms, I think lipohypertrophy, there are mature adipocytes, discrete population causing a localized thickening. It can be on the abdomen, it can be on the arms, it can be on the thighs, depending upon where the patient is putting up the insulin injections. Of course, we discourage the patients to inject at arms. Abdomen is the most common site. The cause of hypertrophy can be because of anabolic activity of the insulin, fat and protein synthesis. It can be seen even with continuous subcutaneous insulin infusion, CSII. Lipoatrophy, they say, is you see a depression on the skin, it's loss of adipose tissue, and we do not know the exact mechanisms, but immunological mechanisms seems to be associated with lipoatrophy, which was more common with animal insulins. Cases of lipoatrophy is that non-purified insulins can cause activation of CD4 lymphocytes, B lymphocytes, releasing cytokines and causing necrosis and apoptosis of adipocytes, leading on to lipoatrophy. So how do you check for lipoatrophy? I think we have to be alert at each visit, especially for type 1 diabetic patients who are on basal bolus therapy, type 2 diabetic patients who are on insulin. We must check the sites. Visual assessment and palpation. I think palpation again is good one, but visually most of the times we are able to make out. Once you are seeing it and seeing it daily into your practices, you are able to make out whether it is lipohypertrophy or atrophy. Ultrasound seems to be very sensitive technique, but I think routinely we are not utilizing it. But these are the characteristics on ultrasound. Many times those hypertrophic lesions which are missed on clinical examination or visual assessment, they are picked on ultrasound. Actually, implication is there if you are able to diagnose lipohypertrophy, dystrophy, because you can tell those patients to change their sites. And we have seen once we are able to tell our patients to change their sites of injections where you are looking for lipohypertrophy, the glucose control is better. In fact, sometimes you have to decrease the insulin doses. And many guidelines suggest that if you are changing the sites from lipohypertrophic site to a normal site, you can decrease the insulin doses by 20 to 25%. So, ultrasound characteristics: heterogeneous ecotexture, absence of vascularity, distortion of surrounding connective tissue, and well circumscribed hyperechoic lesions 3 minutes before the injection. And many a times in this cold weather, they can keep outside. There should not be any issues. So, because of the cold temperature of insulin, it is one of the reasons mentioned for lipohypertrophy. So, once you have made the diagnosis of lipodystrophy, what can be the suggestions to the patients? I think most important is if you have taken a proper history and if you are able to find out the reasons, whether it is because of non-rotation of sites or because of multiple uses of the same needles, patients are not regularly changing their needles, I think it's a good idea to tell them and to correct those deficiencies. Rotation of sites is very important, and changing the needles and syringes at regular intervals is very important. But simply telling the patient at each visit, I think it's good enough. Many treatments have been advised, but I think once the patient stops injecting at the lipohypertrophic site or dystrophic site, then after a couple of months it gets subsidized and the hypertrophy goes off. These are the things which have been mentioned: the local application of corticosteroids, ointments. I do not know how effective, and we do not have much data regarding these local ointments and applications. Few papers talking about liposuction, but I do not think again we have much data. There was one paper many years back talking about liposuction and removal of lipohypertrophic tissue. There has been some animal data. In fact, with continuous subcutaneous insulin infusion or insulin pumps, you can again have lipohypertrophy. In fact, there is no data talking. I was going through the literature whether there is any difference whether you are using a regular insulin or you are using an analog in an insulin pump. But there is no difference with regards to lipohypertrophic as compared to analogs versus conventional regular insulin. But there has been some animal data talking about cannula. We usually asked the children who are on insulin pumps to change their catheters after 3 days. There are extended cannula available and studies going on, but that's the usual dictum. And the cannula, if it is inserted at an angle, tends to cause less inflammation and damage to the underlying tissue. So there was some preclinical data talking about this. And there are cases where continuous subcutaneous insulin infusion has reversed the lipoatrophy which was there with human insulin use. So to conclude, lipohypertrophy is the commonest complications amongst lipodystrophy associated with insulin use in diabetic patients. Regular inspection of insulin injection sites is important. It's important to diagnose lipohypertrophy clinically, visual assessment, maybe supplemented by ultrasounds, because lipohypertrophy can cause erratic insulin absorptions and glycemic variability. Injection site rotation and changing needles at regular intervals is very important. In fact, we published the manual a couple of years back. Dr. Deepak was instrumental in designing many chapters. It contains all of these issues. Insulin injection techniques, type 1 diabetics in this insulin manual. It's available on Amazon also. Thank you, and I welcome you all to our annual endocrine conference February next year.
Any
Site of cannula also to be changed?
Yes, sir. You change, that's a good idea to change. You can use right and left at both sides.
Thank you, sir, for the wonderful presentation. We move on to the next section. Dr. Avdesh Kumar Singh.
Signs of congenital thyroid disorder, for which I would like to call upon the chairperson, Dr. V.C. Bajpayee, the senior physician, Dr. Anand Bajpayee, and Dr. Anurag Mehrotra.